back. You're watching continuing coverage of the World Healthcare Congress, coming to you from Washington, D.C., WHCC 17. And I wanted to welcome our viewers who are joining us via our live stream. In our studio this morning, Dr. Richard Snyder, Senior Vice President and Chief Medical Officer at Independence Blue Cross. Welcome to the studio.
Thank you. Thank you for having me.
You've just finished a panel and you've talked about a wide-ranging number of topics, but you also focused on the current opioid crisis that has been building steam, and we are looking at unprecedented numbers in terms of deaths from this epidemic. How, Ted, do you define it from where you sit, and how did it really begin?
It's an interesting process. You know, historically we've had heroin as a problem in this country for many years, and Philadelphia is sometimes referred to as a multi-generational community of users, in that within a family you can have multiple generations using heroin. And if you look at purity and expense or cost of heroin, we have the purest heroin and the cheapest heroin in Philadelphia compared to other metropolitan areas in the country. But it is a national issue. I know the Philadelphia numbers, so we'll speak to those, but about 900 people died from drug overdoses in Philadelphia last year, and the vast majority of those included opioids. Often laced with things like fentanyl and cataphanil, a veterinary form of a synthetic opioid, which are incredibly powerful. That crisis, I think, originated not only from this sort of underlying use of heroin, but also the suggestion that pain be treated as a fifth vital sign a number of years ago, which led to pharmaceutical firms developing more tolerable and more powerful opioids to deal with that fifth vital sign, resulting in a lot of users. Mm-hmm. And a lot of times physicians unwittingly have been prescribing 30 days worth of pain medicine for minor orthopedic procedures, when in fact the patient may only take 1 or 2 pills, leaving behind a bottle of medications in a medication cabinet accessible to children, adolescents who might want to experiment, and leading to people who are, you know, a population of people who are now drug seeking in a variety of different places and ways. So, you know, you probably have a little bit of convergent evolution between that sort of indolent, low level of usage in the community, coupled with more people finding it hard to get access to increasingly expensive oral opioids.
Mm-hmm. Okay, so we have a good overview of where we are, where we came from, where we are. Where should we go from here in trying to address this growing problem?
That's a great question, and it is a complex question. I recently sat on the mayor's task force to address the opioid epidemic in Philadelphia, and the learnings coming out of that are that it is a multifactorial problem, in that often social determinants are really important at trying to solve the problem. Things such as providing shelter, food, a job, a source of income, to help people get back on track are almost as important as detoxifying them and treating them in both inpatient and outpatient settings. So it's a combination of things, but that's just the treatment part. We really have to go back to the beginning of the problem. I mentioned the fifth vital, the pain being the fifth vital sign, and this notion that you have to treat pain until it's not there, and opioids being kind of the overall blanket. There are some very, very specific targeted therapies that can be utilized for things like migraines that don't involve opioids, drugs that actually address the underlying cause of migraines. For neuropathic pain, like diabetics get painful feet, rather than using opioids, there's a class of drugs that address neuropathic pain very, very specifically. And physicians often either are unaware of, a little bit nervous about prescribing those things, or opioids just become too easy to prescribe. So we have to go back and we have to educate providers. We have to educate consumers, people who consume healthcare, about the risks of opioids. And then more importantly, we need to put barricades in place so that appropriate prescribing is actually delivered. And to do that, we as a health plan can play an important role. Number one, we have an educational vehicle to get to the providers. To give you one example, in 2015 we sent letters to about 1,250 physicians who were prescribing outside of the CDC guidelines for opioids, and provided them a list of their patients who were prescribed outside the guidelines. 1 year later, when we went back and looked at the outcome of that outreach, that educational outreach, what we found is that 55% of the physicians were no longer prescribing, they were no longer on the list. They no longer had patients who were prescribed outside the guidelines. So that can work, education can work. But in addition to that, it's very tempting sometimes when you're faced with a clinical situation where a patient wants pain medicine, maybe they've been getting it from a colleague, and you just really don't know how to deal with that, so you write the script. The way we can prevent that is put prudent pre-certification requirements in place, right? So the highly abusable sublingual forms of opioids, we will not cover them unless you have pain from cancer. Why? Because they're very highly addictive. In terms of total opioids, we currently limit, and in July we'll be going to allowing initial scripts to only cover 5 days of opioids, and also limiting to 90 MEDs or morphine equivalent doses medication per day. And then beyond that, we intend to cover for new patients ongoing opioids for patients who are in hospice or who have cancer. Beyond that, we're going to try to encourage providers and force patients to look at alternatives through appropriate pain clinics that use those very targeted treatments. So on the preventive side, trying to dry up the new substance use disorder patient population, we put the barricades in front of them. In terms of actually treating people who are already addicted, we're taking down the barriers, already have taken down the barriers for pre-certification of medication-assisted therapy, and encouraging that. And the fact pattern sort of behind that is, at a high level, a patient who is addicted or suffers from opioid use disorder and is being prescribed opioids at the same time, which shouldn't happen. We see a total annual cost of about $28,000 a year. A patient who has opioid use disorder and is getting regular treatment without medication-assisted therapy, about $22,000 a year. Opioid use disorder with medication-assisted therapy, about $17,000 a year. And if you have $12,000 a year.
Okay.
If you have no opioid use disorder at all, you're running about $4,000 a year. So there's a strong financial motive. For every 125 people we can take off of opioids who are addicted and move them into a program where they're treated and they have medication-assisted therapy, we can save over $1 million of our members' premium dollars,
Sure.
and that'll help to impact the cost of care.
Now, my own son, who's 18, was prescribed a week's worth of a very strong pain medication for a wisdom tooth procedure. What do providers? That seemed excessive to me, and I'm glad he was educated enough to not use them at all.
Right.
He said Tylenol is fine, but what do providers get for being so aggressive in their prescribing of these kinds of very strong medications? And should more health plans take the lead? It sounds like Independence Blue Cross has taken a lead here.
Right.
Should they take more of a lead in doing what you're doing in Philadelphia?
I think more are. You know, I also chair a group of chief medical officers and chief pharmacy officers from the Blue Cross Blue Shield Association affiliates. And you know, we get together quarterly, and this is a regular topic of our discussion, and I think what you're seeing is more and more alignment of what plans are doing. There's obviously state mandates and things that come into play as well, but plans are doing more in this space. And your example is exactly right. That is excessive. I don't think physicians get anything out of it. It happened to my own daughter. You know, we were cleaning out a closet and found a bottle that had been prescribed maybe 5-6 years ago. My wife had picked it up after she got her wisdom teeth removed. None of the pills were removed from it, but it's sitting in a closet.
Yeah.
If it had been found by someone who, and frequently in the listening sessions that we had with the mayor's task force, we heard that adolescents who are looking often go through family members' medicine cabinets
Sure.
and closets looking for pills
Right.
that are left there in just that format. So, you know, the other role that we've played in that is we support the Take Back program in Pennsylvania, which last year netted 44,000 pounds of medication,
Wow.
not just opioids, but
Sure.
medication that you
Cleaning
don't
it
want.
out,
That's
yeah.
right. That's right.
Well, we're going to have to leave it there, Dr. Snyder, but I really, really appreciate your overview, your comments, your analysis.
Thank you.
Very valuable. May I ask how you're enjoying the conference so far?
Great. Enjoy it a lot.
Very good. Thank you
Thank
so much, Dr. Snyder. And thank you for tuning in. We have many more interviews still to come. Stay with us.